The next stage of change is preparation. So in this stage of change, the person is saying, I'm feeling good about setting a quit date, but I'm not sure I can do it. I'm wondering if I have the courage to follow through. So at this point, the person's actually preparing to make a change. They have acknowledged that a change is needed and that it would be really helpful in their lives, but they're still preparing. They're not quite sure. So in this stage of change, you're doing what's called late persuasion. So before it was early persuasion, now it's late persuasion. So the treatment goals here might look more like strengthening the client's commitment to change, making a firm decision to change, setting up a clear, measurable quit date. Like when are you going to start? How are you going to get there? What are you going to do in your environment to make you more successful in setting that date or achieving that date? Help the client develop self-efficacy, like the client showing optimism that he or she can take action to change that behavior. To identify potential change strategies and choose the most appropriate one. And to formulate steps to reach the goals. So you really want it to be as clearly defined as possible. And also, when you start to formalize these steps, it helps you to identify and deal with any potential barriers. So if the person says, I'm going to do these 10 things in order to get to this quit date, you can say, can you see, when you're looking at these 10 things, is there anything in here that might stand in the way of you being successful? And they might say, oh, actually, now that I think about it, I really depended on this period of time to do X, Y, and Z, but my mom's going to be in the house and she's going to be smoking or she's going to be doing whatever. It helps you to identify and prepare for potential issues and to come up with solutions for them. So the next stage of change is action. So the conflict for the client may be something like, staying clean for the past few weeks made me feel really good, but part of me really just wants to celebrate, So I'm doing real well, I'm proud of myself, it's fine, but I really just kind of want to use. So there is still this significant role in the stage of treatment for this early treatment, late treatment process. So what does that look like? So you're going to work with this person carrying out change strategies, providing support and encouragement to maintain gains received, to reduce ambivalence and transitions from thought to action. There was one person I worked with, and I can share this, first of all, because it's not protected health information, it's pretty vague, but also because I think it's an issue that comes up for most people who go through this process. So this person that I worked with actually had numerous episodes of successful treatment, successful recovery, and a lot of time in this action stage. And what she'd do is once she'd like start out really motivated, really excited, she'd get a pretty admirable amount of clean time. And then would start looking at her life and saying, oh, well, first of all, I'm exhausted. This recovery thing takes a lot of work. And also, I don't have a boyfriend yet. That's kind of, a bummer. And I'd really like a boyfriend. And I really don't have as much money as I thought I might have. I've been looking at all this money I've been spending on using, and now I have extra money, but it still feels like it's gone at the end of the week. So starting to kind of look at the progress and have it be not as exciting as it was early on. And that this actually, for her, set up a trigger, a potential opportunity for relapse for her, because she'd say, well, this recovery business, this action step, is not as fun and as exciting as going and celebrating and getting loaded. So maybe I'll just go do that tonight, and then I'll get back to this kind of not so fun process tomorrow. So being able to help them anticipate and deal with some of those steps and understand that action in and of itself is a lot of work, and maintaining that recovery process is important, and that some of those next step goals would be more in maintenance, because you can't accomplish it all in the first first several weeks, obviously. So during the maintenance phase, the client conflict may be, these recent months of abstinence has made me feel I'm really progressing toward recovery. I'm still wondering whether abstinence is necessary. So here you may have someone start saying things like, it really wasn't that bad, right? I wasn't totally a lost cause. So they might start forgetting, some of those contingencies that were really valuable early on to keeping them focused on treatment. So you'd work through reinforcing new skills that help maintain recovery and a healthy lifestyle. So I guess the point I'd like to make here is that the maintenance stage doesn't mean you're done. It doesn't mean, okay, everyone pack up and go home. They've reached the pinnacle of their treatment. They're good. They're done. It's still a process of reinforcing new skills. For the example that I talked about, for her, it might be if her goal had changed from abstinence and pulling her life together in other ways to really wanting a relationship, and she had had a significant amount of clean time. It might be, how do you move to that next step and set some goals to move toward having a relationship? So let's talk about another case. This is another case example from the book, from the tip. A 50-year-old Liberian woman with a diagnosis of paranoid schizophrenia, Lila. Client permitted the nurse to come to her home to give her intramuscular antipsychotic injections for her quote-unquote nerves. Wasn't for a psychotic issue. She said it was for her nerves. But she would not agree to any other treatment or acknowledge that she has a serious mental illness. She has significant alcohol use with an alcohol level of 0.25 to 0.3 most of the time, with high tolerance. She denies adamantly having used, stating that because her liver is impaired, she simply just can't get rid of the alcohol. So she's denying any current use, even though, it's clear she's drinking. She agreed that she did agree that she believed she has this quote-unquote mysterious alcohol level problem, and she might be willing to get hospitalized for that. Because she wanted to get to the bottom of this. She had no idea how it's possible that she's a level 0.25 or 0.3, but she's willing to get some testing for that. So this is a good example to kind of think through from the context of stages of change and where this woman might be when it comes to a stage of change for both of her conditions. So let's talk about that. So using that stage, what stage of readiness do you think you might consider for her mental disorder versus her substance use disorder? So let's walk through it. So let me see what my next slide looks like. Okay, let's kind of go back. Okay, so here you have Lila. She is obviously not in an action stage. I think we can move backward easier than we can forward. So she's not endorsing that she believes she has a substance use issue. She's not endorsing that she believes she has a psychotic disorder. So we know she's not in an action stage. The question might be, do we think she's in preparation stage for that? Probably not. She certainly hasn't acknowledged that it's a problem and ready to move forward at some point in time on them. Contemplation. Let's talk about the substance abuse first. It's doubtful she's even in contemplation because she is blaming it on this suspicious liver disorder, the reason she has alcohol in her system, which indicates she's claiming she hasn't been using at all and that it's a mystery to her too that she could possibly have a substance use issue. So I think on that side, she's pretty clearly in the pre-contemplative stage of change for that. Now, the psychotic disorder is likely pre-contemplation as well. If she were someone I was working with, I would spend a little bit more time talking with her about what constitutes a nerve disorder, because it could just be that that's how she characterizes her psychosis. And if she came in and she explained that she has a nurse come in and give her a shot for a nerve disorder, but she described to me symptoms of her psychotic disorder, I would probably bump her up to more of a contemplation or preparation there. It could just be that she doesn't get the context of what the psychosis label means. So I would want more information on that, but based just upon the information provided, she's probably pre-contemplative in both. So let's talk about the last step of the assessment process. So we've covered quite a bit, and this is, as you could imagine, a pretty long process. Now, it could be that several of these steps are relatively quick. I mean, they could be lengthy tools. They could also be just brief screens. So if you recall from the last module, a screen could be the cage. It could be just 4 questions, and then you're moving on to the next one. As you become more familiar with how to perform an assessment in this assessment process, some of these may just be intuitive. So as you're working with the person, you're determining level of care, you're determining disability and functional impairment, and you're moving on. It could also be that you're spending a little bit more time and getting more information on those. So when you plan treatment, it's important to recognize that since people who have a co-occurring disorder are not all the same, program placement and treatment interventions are not going to be the same either. That treatment should be matched individually to meet the needs of that person. Treatment planning for COD should be designed according to the principles of the mental disorder dual or multiple primary treatment, where each disorder has a specific intervention that's matched to a problem or diagnosis as well as to a stage of change and external contingency. So integrated treatment planning involves helping the client make the best treatment choice and adhere to consistent treatment. So essentially, you're going to be ensuring that your treatment takes into consideration any issues they have that they're struggling with, and both disorders, and that you're not focusing on one disorder over the other. It is important to note, though, that there are some of your goals that will help with both disorders. So improving family functioning would likely include information and incorporation of substance use issues as well as behavioral or mental health issues. So let's talk about Maria a little bit more. So when you're planning treatment for Maria, you would likely address both problems, the substance use, and if you recall, she has both a history of cocaine and opioid use. So you'd likely be thinking or considering outpatient treatment, motivational enhancement, possibly opioid maintenance. So you might want to consider whether or not her opioid use warrants referral and review of participation in an opioid maintenance program. You'll also be looking at the depressive diagnosis. It's said that she's taking an antidepressant. You might want to consider outpatient and family therapy for her as well. They also alluded to panic, and in the example, they said that her antidepressant was helpful with her panic and her depression. I would want to find out more information about that as well. Like, it doesn't say what type of antidepressant she takes, but I would find out to what extent it's helpful with her panic and what panic means to her. And then also the issue of trauma and making sure that you get enough information about her trauma history and any potential symptoms she's currently experiencing with her trauma to rule out a PTSD diagnosis and to make sure that you're incorporating that in treatment as well. Now, in the example as it's unfolded in the past 2 modules, they have implied that she tends to avoid scenarios that might trigger some trauma-related symptoms for her. So there's definitely an element there that you'll want to take a look at for her. So include for each of the problem areas related information like strengths, cultural issues, etc. She does have a supportive sister, as it indicated in the example. She's motivated. She does have some literacy issues that might be associated with English as a second language, and she has some family history issues. The stage of readiness to change, contemplative action stages, and then recommended interventions. Outpatient psychiatric, consider IOP for her, and goals. So the next step, you'll be wrapping up the quiz for Module 4. And recall that this is the steps 7 through 12 of the assessment process. So with modules 3 and 4, you will have completed all of the screening and assessment information for co-occurring disorders. Thank you.